So, dear colleague, welcome to this sponsor session entitled Lifetime Management, Tailoring Treatment Options to Secure Future Possibilities. So this session is related to TAVI and is sponsored by Boston Scientific. My name is Thomas Cuisset. I'm working in France. Here are my conflict of interest. I have the privilege to do this session with you all in the room and with a great team on stage, with Khaled Al-Shaibi from Saudi, Rachel Bawardi from Saudi, and we'll have the team from Kuwait with Dr. Alinezi and Dr. Halmeri. As you will see, we will share with us a beautiful recorded case. So what we'll try to achieve together during the next 45 minutes, it's first to understand the importance of PVL and conduction disorders after TAVI for long-term outcome. Also to review latest evidence related to lifetime management for patients with aortic stenosis. And also, it's the new wave coming, it's to appreciate the importance of TAVI design on durability and redo TAVI option. So, to do so, after this very short introduction, I will briefly hand over to Khaled, but just to tell you that you can post question, of course, on the iPad that we have on stage, but it's probably even better just to stand and to ask question by using the microphone in the room. So maybe we can go directly to the team in Kuwait by asking Khaled Al-Meri to say few words about the patient you will share with us today, Khaled.
So basically, we always talk about lifetime management, and we had a patient that is young, 52 or so, who's very she's dwarf and slim. Her weight is 35, and she has coronary artery disease with low coronary height. So when we look at this patient, this is the patient that you want to maximize the lifetime management as much as you can. So this is a lady that you want to have access to the coronaries. You don't want her to have a pacemaker. She's very skinny. And you want to have a valve that you can do valve and valve, and you can access her coronaries with low paravalvular leak. So this lady, we wanted something that we can access the coronary.
Hi, good morning.
With a less risk of pacemakers, durable, we can re-intervene in the valve.
Okay, thank you, Khaled. So now we will look at the recorded case, and after we will have time to discuss together about this case.
Hi, good morning. Today we're going to show you a case of a patient who has small annulus and low coronary height, and the patient has coronary artery disease. So we're going to implant accurate NEU2, which is supraannular valve with commissural alignment for the future coronary access, and we'll show the performance of the valve today. Before we go and show you what we are at this stage of the procedure, I'm going to ask my friend here, Dr. Abdullah, who's going to be with me in this case, to present the patient's case and history.
Hello, everyone. So the case we have for you today, show us the first slide, please. So the case we have for you today is a 52-year-old female with a height of 150 centimeters and a weight of 35. So a very small body surface area. Next slide. Her risk factors include diabetes mellitus and dyslipidemia. She has been bedridden after she developed a hip fracture, and she does not have any cognitive impairment. Next slide. So she was admitted to hospital with non-ST elevation myocardial infarction, and following this medical treatment, she continues to complain of exertional dyspnea. She had coronary angiography, which showed 3-vessel disease, but the culprit was thought to be the proximal RCA. Next slide. From blood work standpoint, she has hemoglobin of 10.6. Kidney function is normal for her weight, and LDL of 0.6. Next. In terms of echocardiography, as you can see, that the aortic valve leaflet seems to be thickened and restricted, and in the short axis we can see that it's a tri-leaflet aortic valve. Next slide. In terms of left ventricular systolic function, it's normal at 65%. She has grade 2 diastolic dysfunction. She has only mild MR and severe aortic valve stenosis with an aortic valve area of 0.35 centimeters squared, with indexed aortic valve area of 0.3 centimeters squared, with a mean pressure gradient of 47 millimeters mercury. Next slide. So CT angiography, it's a very small, difficult to see the numbers from here, as you can see on the slide, but the numbers that she has in terms of perimeter and the average diameter goes with a small size accurate neo valve. The important point to highlight that the coronary heights are really low, especially the left main at 9 millimeters. Next. This is the measurements. You can see tri-leaflet. The valve actually is not as heavily calcified as we expected from the echo, but it does have some mild calcifications. Next. This is just to highlight the coronary height. The right seems to be okay, but the left main is low at 9 millimeters. Next. The femoral access actually does not have any calcifications to speak of, but the diameter seems to be very small, measuring 4.5 to 5 millimeter in diameter, which might be a little bit challenging, but we are hoping that the vessel would distend and stretch as we pass the sheath, given that there is no calcium. Next. So the strategy, Dr. Khalid, for our case today is the use of local anesthesia only. We're going to perform coronary angiography, which was already done. We're going to use both femorals with ProGlide for closure. As you know, with the accurate neo, we always have to pre-dilate the valve, so we're going to pre-dilate using 18 millimeter balloon. We're going to use commissural alignment because it's very important for this patient for future coronary access. And we're going to use accurate neo 2 size small. And the plan is that we're going to implant it under rapid pacing because the annulus is really small. So we want the valve to be really as stable as possible.
Great. So now we're going to show you now what we have done so far. We'll go and show you the coronary angiography now. Go next, please. So this is the right coronary artery. You can see severe disease from ostal to mid. And whenever we select the ostium, the patient dampens, and it takes really time for pressure to build up back again. And because of that, we decided to do TAVI first, then do the coronary angioplasty after. Go next. To be frank with you, the first coronary angiography was done in a different institution. We think the circumflex artery is moderate and LAD moderate to severe. We'll show you the next image. After implanting the valve, we'll just evaluate the LAD with imaging and see whether we need to do a PCI to that or not. Next. So now I'm going to show you, those are the angle of implantation. This is a 3-cusp view. And then the next one is cusp overlap view. You will see it now. So because the patient is like, here we have a patient who's really small and tiny, and as if we are doing TAVI to a child. So we could not go radial, which is our usual practice. So we access the common femoral artery on the right side and common femoral artery from the left side and put the pigtail, and we put temporary pacemaker on the left side. We usually do RV pacing. We don't usually do the over-the-wire pacing. Now we have crossed the valve with confida wire. And what we have here available is Safari Small. And the lobe of the Safari Small is big for this LV. So we chose to go with confida in this patient. Although the Safari give you better orientation, and it hugs more the outer curvature of the aorta, which is needed during implantation accurate neo. So now we are going with an 18 balloon. You can see the pigtail in the non-coronary cusp, and we'll do with rapid pacing the balloon valvuloplasty. Ready?
Yeah.
Okay. Case.
Pacing started.
Okay. Plate. Deflate. Stop pacing.
Pacing off.
So you can see the balloon valvuloplasty has gotten really nice. No waste. We are keeping the pigtail in the non-coronary cusp. Now we're ready to go with the valve. Here we want to see the three commissural posts next to each other, and you see them clearly. And then after that, we go to the two cusp view, and we'll show you we should see a free cell toward the right side hand of the screen. Go to the two cusp view, please. And you can see here there is the free cell is to the right side of the screen, and means that we are commissurally aligned. So the deployment of the valve should be in a three cusp view. We'll go into that view. Yeah. And the pigtail should be deep into the non-coronary cusp, but the valve should be hugging the outer curvature, so we're going to push it more to the outer curvature, please. Push the wire. Yeah, yeah, we'd like to see it that way. Good. I think we'll take an image here. We need to be slightly lower. This is good. Okay. So we want the dot at the level of the annulus. So we're going to start to release. There are two buttons. Dr. Abdullah will tell us how to release a accurate knee 2 with those two buttons.
So I think one advantage of this valve is it releases from top down. So we start by releasing number 1, and then we'll reach a stop. Then we have to release the knob 2, and then release the knob 2 very quickly. So the knob 1, you'll see it will be released very slowly. So I'll start, Dr. Khalid. So we'll do one rotation
until we see the crown.
1 and stop. 1 and stop. This ultimately.
Okay, so we release the crowns now. Now we have time to position it, so we think we need to go slightly lower. And we have to say the last movement of the valve should be forward.
Yes.
Okay, I think we're fine there. We start releasing the arches.
So very slowly, knob 1. See, the valve is very stable. Okay, I'm hard stop now.
See, we're in a good position. At this stage, you still can't push the valve. So now, if we're happy with this position, we'll pull the pigtail back. And in this patient, as we said, because of the small annulus, we want the valve to be more stable with rapid pacing. So we're going to do rapid pacing here, and we'll release the second knob. Okay?
Okay, so I just want to highlight the point. So to release number 2, you have to push on this and remove this safety key. And now we are ready to deploy the valve once Dr. Khalid is happy.
Yeah. Yeah, I'm going to apply forward pressure here. Okay, pace at 180.
Pacing started.
Okay. Now we're doing rapid pacing with fast release.
Half stop.
Stop pacing.
Pacing off.
Now we're trying to take the, okay, slowly we take this back, push the wire in. Good. An important thing during the deployment, you should always keep forward pressure. So now it's time to close the system, and we do it the other way around. And I'll show us how to do this.
So number two, we started by releasing number one, then number two. Now we have to do the reverse. We'll do number two and then number one. Number two, we can do it quickly without even doing fluoro, so the opposite direction to opening the valve. So that's done. But number one has to be done under fluoro to make sure we don't expand the system, which we might make the arteriotomy in the artery bigger as we bring it out. So I think here it's good.
So now we have a pigtail in the LV. We exchange the stiff wire with the pigtail, and we have pigtail in the ascending aorta, and we can see there is almost no gradient across the aortic valve. And then we'll evaluate the AR. 1820. So we're too close to the valve. I'll just pull it up. And you can see there is zero gradient. You can see the coronaries are open. The left main is open. And we'll see it there.
There's no AR.
And there is no AR with zero gradient. So we have seen here a patient with really small annulus, with small vessels, low coronary height, who's young. She's 52, and she has coronary artery disease. So we want to avoid pacemaker. So now we have narrow complex. We didn't have any conduction issue after implanting the valve. So we want to have a good hemodynamics, and we have zero gradient. You have no AR. And you want to have the access to the coronaries available when you need it, and you can see the access is fine. This is 2, 3, and the fourth one is you don't want to have a coronary occlusion, which is this patient was high risk for that because she has low coronary height, she's female with small sinuses. This is the other thing. The other important thing is the future, lifetime management. So in case of this patient need another valve with this commercial alignment feature, so we can do leaflet laceration or basilica to facilitate future valve on valve. So in this lady, I think this valve was really the ideal valve for this one because of those multiple issues. So what do you think, Abdullah?
I think that's you drive all the messages home, and I think the other important point, the patient is still in sinus rhythm with a QRS that's narrow. In a young person, you want to avoid multiple devices like pacemaker. So I think this is another advantage of this valve, that you avoid pacemaker implantation because it's associated with low percentage risk of complete heart block or advanced heart block.
Yeah, thanks a lot. I think we can applaud because it's a beautiful case, and no, it's a nice example in very young lady with small annulus, because at 52 probably the concept that we speak more and more, the lifetime management really makes sense. I think when you're 50, and it's a beautiful example. Maybe you can stand, ask any question and comment, but I would like to start. Always the first question that we have in mind with such patient is about the patient selection, because now we have different THV device, supraannular, self-expanding, balloon expandable. So Rasha, for you, focusing on the accurate Neo 2, which are the main criteria driving your choice toward this specific THV device in your practice?
Excellent case, nicely demonstrated. You guys made it look really simple. I think, as you said, the platforms are out there, but there are certain patients that will definitely benefit from specific platforms. So here we have a small annulus, so we're looking for supraannular. The concern, she's young, patient prosthesis mismatch, although I'm not sure with the dwarfism if the data applies to her, but definitely it's a concern. Low coronary height is definitely an advantage in using this valve. There's not much of calcium in the LVOT that you would worry about annular rupture with pre-dilation, post-dilation. So definitely she's the best candidate for this, given that, and the pacemaker rates are extremely lower than the supraannular other platforms. So you kind of have all the advantages for this patient using this platform.
Yeah, thank you, Raja. Yes, please.
Great case, great selection. Just a question about the low-lying left main. Again, this is when this valve came out before Boston acquired it. The London group published there is 0 left main obstruction. The randomized data did not show a difference between the two platforms because they were carefully selected. Would you say that now, in the current era, would you reach for this valve for any cases if you have a low-lying left main like your case? Is this a fair statement, or you do not have the data for that?
Yeah, I think it's a very important point. If you don't mind, the second step of the session will be focusing on the, discussing the latest evidence with the NEO2. But I agree with you that thanks to the recent scientific evidence we had, we have very reassuring data to put the accurate NEO2 as part of the routine practice and not only for selected cases. I've seen that, Khaled, we have just a couple of
questions here, yes, from the audience. And whenever we speak, or many people, when they speak about lifetime management, a lot have the preference of using a balloon expandable intraannular valve that has a lower chance of later coronary obstruction with the implantation of the second valve. And the person in the audience here, who's anonymous, is asking, you have implanted the supraannular valve here, and she does have a low coronary obstruction. So are you worried about future TAV-in-TAV implants in this patient?
Sure. So this patient, balloon expandable, it was out of that range, and there is risk of rupture, and she will have a gradient. This is one thing. But we believe that if you have a good hemodynamics from the beginning and you avoid gradient or mismatch, maybe that will reflect even on durability of the valve. And if you can cusp overlap and do the alignment, then you can deal with the leaflet later on, and then you can do laceration or leaflet modification.
One other technical question from the audience.
Just following that, just one point. Following what you say, the commissural alignment is key, because if we want to do shortcut in Basilica when she will be 70. But beside that, do you think that we can say that the supraannular THV device are just all the same in one box? Or because of the specific frame of the accurate NEO2, we know that the redo TAVI might also from bench test easier, because you will be able to put balloon expandable one probably lower, yes. And thanks to the design of the valve, you will still have some space between the valve and the aortic wall?
Yeah, I totally agree with you. If you implant the balloon expandable in those patients at the inflow, you will have, let's suppose that way, you will have less leaflet hangout. And if you want to implant it higher, you will have to implant it slightly higher than other valves, or lower than other valves. So I agree with you, yes.
We'll have a little bit more leaflet overhang, but less occlusion.
So I guess the point you're making here is not all supraannular valves are the same. And that, the question that he asked may be more valid had this been a Medtronic valve implanted rather than a Boston Scientific NeoAccurate valve.
I think if you choose one platform, I think you will be able to do all TAVs in 90% of the patients. So then you will have this 10% that you will not be able to use this specific valve, whatever you choose. So I think you should have alternatives. So each valve has some advantages that can be for certain patients.
Another question from the audience, a more technical one, maybe to Abdullah. Do you always rapid pace when deploying this device?
Simple answer is no. Many times you can deploy it without rapid pacing, but we like to rapid pace because it gives us comfort that the valve will not move. And that's why Dr. Khalid highlighted multiple times during the procedure that the last movement has to be forward, because as you saw, the valve is deployed very quickly, the second step, and you don't want the system to be under tension, otherwise the valve can embolize. So last movement forward is very essential. Pacing just gives us more comfort that the valve will not move.
And maybe staying on the coronary access, we have also an important question. We've seen very young patient, 52. She had a, let's say, ostial lesion on the right, intermediate lesion on the LAD. Does the fact that you select a THV device with easier coronary access also a little bit drive your decision to say we will see PCI maybe later, while with other device, maybe you will have fixed the coronary first and then do the TAVI?
Yeah, this patient, we were planning to do the coronaries first. The thing is, whenever we selected the right coronary artery, patient just drops her pressure. So we knew that she will not tolerate revascularization before the valve. So this valve was ideal for this patient, so you know that when you deploy it, you can reaccess the coronaries with no problems.
And maybe on this point, Raja, what is your practice about, the concept of PCI or TAVI? We know that it should be tailored because there is not one rule, but usually what you do as of today?
Yeah, so I think we know from the data that you don't really have to do PCI unless it's left main or a really significant lesion in terms of angina. But doing it pre-PCI is really has not been shown to be beneficial. If anything, might be actually worse of kidney renal failure in those patients. So you've demonstrated nicely a very significant osteal RCA, patient symptomatic with selection, but managed to do it with multiple rapid pacing, both with pre-dilation, post-dilation, and during the valve deployment, and patient remains stable. So this is just an example that you can actually do rapid pacing with significant lesions and patient would be stable.
That's exactly the practice we have. We do less and less PCI before TAVI, and we even stop to do invasive angio for all the patients, while in probably half of the patient we try just to do CT based on the CT, and then we can do that in the day clinic without any hospitalization for the pre-TAVI screening. I think that's a...
If you allow me to comment, I think our practice with this, we have experience with doing PCI regards timing of the TAVI and PCI, and we find doing PCI before you do the TAVI is quite risky. We have some patients arresting you doing PCI because you have severe AS and now you're occluding the arteries. So we tend to like to do it after we do the TAVI. The only cases we would like to do it beforehand is the cases where we're worried that we won't get access to the coronaries. But I think having a platform that you feel confident that you can commercially align, you're not going to have a problem with accessing the coronaries, gives you that confidence. You put the TAVI, and now you're doing a more relaxed BCI.
Yeah, and this patient, Thomas, had a non-sterilization MI. So that we had to do the revascularization. She's admitted with non-sterilization MI.
And maybe one word, because we know recently that the benefit of commissural alignment is going beyond coronary access. We've seen the work from Copenhagen showing that when you do commissural alignment, you will improve coronary access, that for sure. But also we will reduce the rate of PVL, we will improve hemodynamics. So I think that's really something key that we have to do with a specific device.
I think you've just answered a question that came up.
Sorry.
Do you perform commissural alignment routinely, and is there evidence of benefit, the risk to doing it?
Maybe you can practically explain how you try to optimize commissural alignment with the Accurate Neo 2. You nicely explained that you need to see on the right part of the screen the marker when the valve is in, but before, can you explain how you try to engage?
So to answer the first question, we have some evidence that it's pretty safe, because the main concern when trying to commercially align that you are manipulating the device and the aortic arch, and the main concern is stroke. And thankfully, we don't have any data to support that there's increased risk of stroke. It's probably safe. So to do proper commissural alignment, you need to have the two views, the coplanar view and the cusp overlap. And with the Accurate Neo 2, you have open cells. So you start in the three cusp view, and then you can look to have two free cells on either side. That tells you that you are either perfectly commissurally aligned or perfectly misaligned. So to make sure that you're not perfectly misaligned, you go to the commissural overlap, and to see that the open cell, which correlates to one of the commissures, is to the side of the cusps overlap, which you will need one cusp on that view. Yeah. And then you're happy.
So thinking about lifetime management, we discussed the redo TAVI option, which is probably easier with the Accurate Neo 2. We discussed the commissural alignment. What's your view also on the conduction abnormalities with this platform, Rasha? Because it's
single
at 50,
digits.
it means something to have a pacemaker, probably.
Yeah, so compared to other self-expandable, it's actually single digits, 6 to 7%, even with the newer platform. So definitely lower than the others, especially in this case, not only that she's young, but it seems like she's very thin. So risk of infection, risk of bleeding from the site is also a concern.
Will be increased, yeah. And Khaled, we've seen in this case that you did, of course, small balloon, but predilatation. That's practice for all cases with the Accurate Neo 2, or you still have some selected case with lower calcium burden when you try to do what we used to call direct TAVI?
Unfortunately, we have to predilate with the Accurate Neo. We never done it without predilatation.
Well, I think which is reasonable. Yeah. And we see that also the trend with other self-expanding device like the Evolute, that the rate of, we used to do predilatation, and after there was a big let's say, fashion of direct TAVI, and now we also increase a little bit the rate of predilatation with other devices. So I think that's, yeah. No, he's leaving. I thought he was standing for question. So do you have any other question about the patient selection and the concept of lifetime management? And again, thanks, because to have TAVI at 50 really improve the quality of the discussion, because the concept really makes sense. Yes, we just have a question here.
Any concern about calcium distribution before you plan your patient, whether it is in the LVOT, eccentric nodule, etc.?
Abdullah, I think Khasha covered a little bit that, but maybe you want to discuss?
Yes, I mean, every time you balloon the aortic root and there is calcium, there's some concern. But usually we are very conservative on the balloon that we use to pre-dilate for the accurate neo. So we haven't seen any problems with regards to pre-dilatation. But I think pre-dilatation is very, very essential to the procedure. Even in our case, if you notice, she was 52, so you would expect that she has bicuspid, but she has tricuspid. So we're suspecting maybe she has a rheumatic cause for her aortic valve. So even you don't see calcium, the valve might be resistant to pre-dilatation. So it's better to pre-dilate it before you implant the valve.
Yeah, and it improves both crossing, deployment, so it makes everything easier. So again, thanks to this case, I think we had that discussion about which patient is the ideal one, concept of lifetime management, and to first, because the long term is good, but to optimal procedural result also, it's probably the first step. So beyond that, following the comment we had, we like to ask you to cover the latest evidence for accurate Neo2, please.
Okay, thank you, Thomas. This mic going, okay, perfect. So we'll show you some of the objectives of this talk. It's a short talk. We're just going to talk about the new design of the accurate Neo 2 and how is it different from the accurate Neo 1. And we're going to talk about some of the initial data that we have with regards to the PVL, which was a major concern with regards to accurate Neo 1. And maybe some on durability from bench testing, commissural alignment like we've shown has done, and we get some data on that and some real world data with the new device. So with regards to accurate Neo 1 and 2, the major changes, before we go to the changes, the device has a lot of similarities. It does have the stabilization arches, which you see them in the top. You have the supraannular leaflets, upper crowns, lower crowns, and each one component of these the valve has its advantages. The stabilizing arches helps to center the valve. The supraannular feature is very good for small annuli, so it gives you good hemodynamics. The upper crowns is really good to hold the native leaflets and reduce the risk of coronary obstruction. A lower crown has minimal protrusion in the LVOT, giving you low risk of pacemaker. The changes with the accurate Neo 2, first of all, you can see the outer skirt is 60% longer, and it has this mechanism of called active paravalvular leak sealing. So this is a design to meet clinical need, and this is really nice because you will see in the next picture, if you look at the red arrows, during systole, the valve is open, and you can see there is an area that is not completely sealed. But during diastole, when paravalvular leaks occur, you can see that some of the tissue of the valve moves to occlude that hole to reduce the paravalvular leak. And this, I think, is very attractive in a situation where you have a calcified nodule, for example, where you cannot completely seal the aortic annulus. And even if you post-dilate, you cannot completely obliterate that space. But having this active seal technology, you would think we would help reduce the paravalvular leak significantly, which was one of the shortcomings of the previous iteration of the device. Another nice addition, and you saw it from our live case, is having radio-opaque marker. Before we had to imagine the marker. Now we do have a marker that we can actually see. We can confidently position. And one thing really nice about this valve, even though it's a self-expandable valve, the deployment is very stable. And once you position it in the right position, it tends to stay as long as you do it right and you make sure the last movement is forward. And maybe I go back. And the other thing that you can see, an opening cell just above the marker, that's what will help us get commissural alignment. That's another big advancement with regards to the newer iteration of Accurate Neo 2. This is an analysis of multiple trials using root angiogram done after the procedure to assess the degree of paravalvular leak. And this involves 11 different devices. The good thing, you can see both Accurate Neo and Accurate Neo 2. It's almost like an indirect comparison. And you can see with the Accurate Neo, the first one, the significant moderate to severe was 11.3%, so that's relatively high. But when you look at the Accurate Neo 2, which is the first one on the left-hand side, it has great paravalvular leak numbers. It's even comparable to the Lotus, which is well known to have the best paravalvular leak reduction. So really, really reassuring data that the change in design had led to significant improvement in clinical outcomes. What about the price do you pay with increasing the skirt? We saw that with other valves. When you increase or change the outer skirt, you pay a price with increased pacemaker rates. But from NEPRO 2 registry that looked at Accurate Neo and Evolut R, that outcomes were very similar. But the interesting point is the risk of permanent pacemaker stayed at single digits for the Accurate Neo 2. So the change in design led to reduction in paravalvular leak, but we did not pay a price in the increased number of permanent pacemaker. What about durability? I mean, FDA, maybe CE also would require at least 200, the valves to be to test it with 200 million cycles, with that equals 5 years patient's life, to make sure that the valve doesn't deteriorate. Actually, with the Accurate Neo 2, it was tested to 1 billion cycles. And despite that, the valve was maintained and surpassed the ISO requirements for regurgitation fraction and effective orifice area. So this bench testing data, and we have to wait and see it on real world data, but this is really reassuring and promising that the durability is going to be better with this new design. What about commissural alignment? This is a COMALINE study that looked at 60 cases that divided between Evolut R, Evolut R Pro, Accurate Neo 2, and Portico. And you can see in the middle with the Accurate Neo 2, 0 patients out of the 20 had moderate or severe commissural misalignment. As a matter of fact, the majority were completely aligned. Very small portion had mild misalignment. So from a commissural alignment standpoint, Accurate Neo 2 is probably best in class. What about a new aligned study? It's again looking at commissural alignment, but bigger number, 170, and very reassuring data that 97% of these patients had no significant misalignment. And as you know from patient lifetime management, coronary access in the future, this is crucially important for our patients. And despite this, there was no price to pay with regard to safety. So manipulating the device to get commissural alignment did not specifically increase stroke, which is a major concern that we have. This is the early Neo 2 post-market registry with Accurate Neo 2, and the numbers, again, very reassuring. The 30-day data, mortality is low at 1.3%, low stroke risk despite that we are pre-dilating in all patients, pacemaker 6%, and mean gradient, great hemodynamics, single digits. And again, the paravalvular leak, any moderate paravalvular leak is less than 3%. So I think the take-home messages with the new iteration of Accurate Neo valve, that it's really significant improvement in design that led to improvement in outcomes. And with the active paravalvular leak sealing system, they had a positive impact in outcomes, and we did not pay a price for with increased permanent pacemaker. And with regard to commissural alignment, I think Accurate Neo is one of the best valves with regard to commissural alignment. Thank you.
Thank you, Abdullah, for this very clear update. And as you say, it shows really reassuring data, because we had Accurate Neo with, for example, the scope result exactly as you mentioned. And we've seen really a clear difference with Accurate Neo 2, solving the PVL issue, because as you said, thanks to the design of the valve, the rate is not as low as compared with balloon expandable, for example, but without the price of increased gradient, increased rate of pacemaker. So it's, as you said, I think it's really one of the best in class today for TAVI practice. Khaled?
So really, I think as we're talking about lifetime management of these patients, And you talk about lifetime management, we're addressing younger patients. This was an extreme. I don't think most of us here in this room are ever going to put a TAVI valve in a 50-year-old, but there were extenuating circumstances. We fully understand that.
It's exactly as if you have a 14-year-old child on the table. That's how it looks like.
I fully understand. So when we talk about lifetime management, you want to give these younger patients the best possible result. To get the best possible result, you want to give them a valve that has a very low paravalvular leak. We know aortic regurgitation adversely affects long-term outcome and mortality. These young patients are going to live for another 20, 25, 30 years. You don't want to have them be pacemaker dependent and have to go through all these pulse generator changes over years. So another key important thing when you talk about lifetime management and implantation of valves in these young patients is trying to avoid not only a paravalvular leak, but also to avoid a pacemaker. Another thing, you want these valves to last for as long as possible. And the lower your gradients at initial implantation are, the more likely this valve is going to last for a longer time. And having a supraannular valve with a larger mean orifice area and a lower gradient, again, may enhance the durability of this valve long term. And finally, when you're talking about lifetime management, coronary access always comes into consideration. And as Dr. Ennezi showed us here, this valve has a very high level of commissural alignment and hence has the ability to maintain coronary access. So all the criteria you look for when you talk about lifetime management in a young patient are fulfilled by this valve.
Thank you, Khaled. I think we were about to close the session, but I think we cannot leave without your question, please.
Small comment, within our region, we are dealing with list calcification. Do you think the sponsor of the session would be interested in doing a local registry in our own country to see the performance of this valve within our population?
It will be starting very soon, the MENA TAVI registry.
Great.
It's a visionary comment because it will start very soon.
Thank you.
So thanks for joining and enjoy the end of the meeting.